Good afternoon, everyone. We're going to give folks a couple minutes to get settled in and dial in. Hey, good afternoon, everyone, and welcome. Thank you for joining us for today's seminar, Billing and Compliance in CIED Remote Monitoring. At PrepMD, we believe education is one of the most powerful tools available to strengthen device clinics. That's why we continue to invest in bringing practical, real-world education to this community, not just around clinical care, but around the operational and financial challenges that directly impact a clinic's ability to succeed. Today's discussion is especially important because billing and compliance have become increasingly complex, yet they remain critical to the long-term sustainability of remote monitoring programs. This session is designed to provide a fresh perspective on how clinics can approach billing, compliance, and workflow optimization in a way that supports both patient care and financial performance. We're fortunate to be joined by two people who understand these challenges firsthand because they live them. Beth Davenport is a cardiac rhythm management and device clinic leader with nearly 20 years of experience in device care. She spent more than a decade leading device clinics at Seckinger Heart and Vascular Institute, overseeing virtual care programs, multi-site operations, and system-wide workflow improvements. Today, she serves as a clinical transformation specialist at BIOTRONIK, where she continues to support the advancement of modern device clinic models through education and innovation. Joining her is Kent Seckinger, Director of Consulting Services at PrepMD. Kent has extensive experience across both clinical and industry settings, including years working with the device clinic at Emory and on the industry side with St. Jude Medical. Today, he leads PrepMD's consulting team, helping device clinics improve workflows, operational efficiency, and patient care outcomes. Before we begin, a quick housekeeping note. The Q&A function will remain closed during the educational portion of today's session. We encourage you to jot down any questions if you do have them throughout the session, and we'll open up the Q&A at the conclusion of the presentation to allow time for a discussion and audience questions. Beth and Kent, thank you both for being here, and I'll turn it over to you.
Thanks, Kate. Appreciate it. And I want to thank everybody for being here. This is going to be a great conversation, I think. And before we really get started, I want to take off a little bit of pressure. This is not intended to be a formal billing and compliance lecture or anything to that nature. Beth and I just want to have a conversation basically around CIED remote monitoring. And we're asking the specific question of what kind of service is this? And I think that's very important to look at in this day and time because it has changed rapidly over the years, probably one of the most rapid changing technologies that we have to this day. So again, it's changed faster than really any of us could keep up with the language that we use to communicate it. So that whether it's a clinical team, billing teams, compliance teams, we've all kind of inherited this way of looking at CIED remote monitoring from really an earlier era. And it's not something that anybody's behind or needs to catch up. It's just the nature of how fast the technology's moved. So, and I'll start off just by saying that, for a long time, the earlier era has treated remote monitoring in the CIED world more along the lines of ambulatory monitoring, kind of like a Holter. You wear it, you send it, a physician reads it once, and that's the service. It's over. So it's a single moment, a single interpretation. But as we've discussed this with many different clinics that I've worked with across the country, it's kind of the same conversation that comes up, and it's not really the reality that we live in anymore with this type of remote monitoring. So, and that's one thing that Beth and I really want to look at together and talk about how this is a different, but still talked about from an older era. So Beth has lived inside this for quite some time. In her experience, I've had some experience with it as well, internally with a clinic. And also too, to that, I've also worked with several institutions across the country that seem to struggle with this, talking about CIED remote monitoring in a new era. So, Beth, if you don't mind, if we can turn it over to you, and let's have a discussion around what kind of service this actually is and what we see.
Yeah, so to your point, Kent, we've both had our experiences as this technology has changed. And, for more than 20 years, I worked in and eventually became the director of a large device clinic. And as the technology evolved and clinicians and patients got more comfortable with remote monitoring, it really wasn't that long before we weren't just seeing patients every 3 months in the office or every 6 months in the office. And we went from, to your point, getting, so basically with, before RF, yes, we had home monitoring, but really what we were doing was asking patients, instead of coming into the office, sit with your monitor, push a button, hold this over your device, send us a transmission. It was still a point in time service, right? It was still, and then at that point, we could see what had happened for the previous 3 months, what diagnostics had been recorded, those kind of things. I would say that for us, COVID is really what catapulted us and just shifted things very quickly from that traditional one and done patient encounter to
Mhm.
engaging in this continuous home monitoring on all of our patients. So, it was almost like overnight, suddenly keeping patients safe and engaged with their care and keeping an eye on their device was about keeping them connected to their home monitors. But the language around it, and again, when we look back and we think about COVID and we think about home monitoring and we think about this technology, I'm sure we weren't the only clinic that this just hit like a ton of bricks, right? All of a sudden,
Mhm.
you're like, okay, we have to take care of thousands of patients from their homes. But the language around it and the billing conversations and the way the institution understood what we did, it was still all kind of stuck in that old world of scheduled office check and scheduled remote downloads,
Sure.
right? Which
Yeah.
is completely different. And so
Mm,
this
Make
technology and what we're talking about really is, it's so different now because it's continuous care.
yeah.
And we've got this misalignment where clinical teams are, they're taking care of these patients continuously. They're not, there's no stop, right?
I
Yeah.
would say maybe, you mentioned the COVID era that really picked off or really picked up a lot of everything that was going on, as people now didn't come into the office every 3 months or every 6 months. They couldn't, of course. And then even a big part of the technology that really changed was the capability from going from inductive to still being that kind of scheduled point in time, one and done almost, because it's just, instead of the patient coming in the office, like you said, they could just send from home, but it was still more or less that kind of like that single read that they have. But then when RF came in, that really, I would say that in conjunction, because that was available before COVID, but we
Right.
started to see all of this, and then the introduction of ILRs into the therapeutic device population too. So now all of a sudden, no longer do you have a point in time single interpretation. This is ongoing. RF capability allows these devices to pull with their transmitters. Now they're on people's phones with apps. So
Right.
wherever
Right.
you go, these can be triggered at any given moment during 24/7 almost. Yeah.
Right, right. And, we can't forget that we've set red alerts in some of these. We've set yellow alerts in these, right? So what I mean by that is, red alert is potentially life threatening. We need to be ready to handle that 24/7. Yellow alerts, same way, right? And when we talk about continuous home monitoring, so going back to when we really noticed this shift, for a while, yes, we were getting alerts, but we still felt like it was something we handled in between the device checks in the office. And it was something that was sort of extra, but it wasn't our main way of taking care of patients. Our main way of taking care of patients was having them come into the office. So now, now our main portal, our main way of providing care to patients is through that home monitor. It is
Mhm.
through getting not just the diagnostics if there's an alert, but also doing that every 90-day report that says this is what has happened over the last 90 days as well. And I do think that's where, and we'll talk about this more, but I think that is part of the reason that even though as clinicians we know what we're doing, we're still sort of stuck because we think about we're doing a scheduled transmission every
Right.
91 days. But we really need to think about, and I know what we're going to take a deep dive in is why are we like, why is
Mhm.
that still different? Why is that still continuous care, not a one and done encounter?
No, I think that's a great point. And it does, the language of just saying a 90-day scheduled remote very much does, fall back over into the concept of being ambulatory monitoring. It's that 90 days. Here's the report that comes over. If it's a CIED, the interpretation needs to take place, and that's it. So that's really the older model that it was viewed at. But if we look at some of the examples where we could take a 90-day service window, and you and I've talked about this a little bit. And if you have somebody that's on an advisory or an accelerated follow-up, you could schedule somebody for various different time frames. Um,
Right.
yeah, could you give a couple of examples of where something like that would happen?
So, oh, you mean, so like, let's say you have a patient who is, let's say they're affected by an advisory and their battery is also nearing ERI or they're pacemaker dependent. And so we're going to need to check them once a month. We need that transmission to come through once a month. We're
Mhm.
not going to get paid for it once a month, but the purpose is that we need to do that home monitoring because it's a patient safety or it's part of an advisory or the patient is having RVR, they're having high ventricular rates and the doctor puts them on a new medication and he wants to know, is it working or not? Well, we can determine that without the patient coming in. We can actually have them we'll do a transmission in 2 weeks. I'll schedule downloads so we can check on it. I'm going to write that report up. I'm going to send it to the physician. Can I bill for that home transmission? Not unless it's been 90 days since the
Right.
last time I billed, right?
Right.
So, but we'd still deliver the care.
Yeah. And
Um,
importantly, even during that period of time, because what we think we're trying to connect here is that the actual scheduled delivered report can take various different forms, whether it's for patient safety, if you're going to, if you're going to increase that frequency, it's not just a 90-day report. And then also being that they're RF capable, you can still continue to get on a daily basis an alert transmission for a new clinical event. You can have patients send in automatically on their own. You can get, arrhythmia alerts. You can get device function alerts. These can come
mhm.
in all the time. So that's back to the continuous care model. And even if something doesn't come over, there's always the potential that something is there. And so a clinic has to have the manpower and the resources to be able to do that. It is the standard of care now that we have. But to your point, no matter how many transmissions, and we'll go into this in just a minute, no matter how many transmissions come over, how many analyses are made, how many times the physician reviews one or signs off, the you can't bill any more frequently than 90 days.
Right,
Yeah.
right. Yeah, but what we're trying to prevent is people not even doing that, right? So, I would say that there is this, again, if you're hamstringed and people aren't on the same page about what that billing really is, what you're billing for, but also how you're billing it and what that really means. Because what you don't want to do is if you're not billing correctly for your services, how are you going to, and you don't have that revenue integrity, how are you going to show the work? How are you going to support having the staff that you need, the CRM software platform that you need to help you manage
Mhm.
all this stuff? Because you do have patients affected by advisories. You have patients that are, that need that management. You're doing the documentation. You have to have some way of making sure that you have billed at least every 90 days because you need to provide that service. And that readiness is where I
Mhm.
think people need to understand. I have to be ready. I have to have a staff that's trained and ready, and I have to have the workflow structure and framework in place in case something happens. And I think sometimes we get too caught up in, well, this patient didn't have any alerts. Okay, but what did we offer them? We monitored it, we looked
Right.
at it. Their monitor became disconnected. What did we do? We called that patient to get it reconnected.
Right.
That's the work that we're doing
Yeah, and it's
continuously.
can change. And again, when you add in the just speaking to the RF capability of these devices now, and CIED devices, if we go back to where oftentimes um, CID remote monitoring is kind of bucketed in that ambulatory language model of which I've talked with several different institutions, and the conversation is generally the same a lot of times when they start to come together on billing this or if there's problems with it, and it tends to always go back to the ambulatory model, which again we have to illustrate is it's whether it's a 24-hour Holter, 48-hour, 30-day MCOT. That's a service that's done once. Patient wears it, sends it in, physician reads it at the end of the period. Whenever that physician signs off on it, that would be his signature for the completion of the service, the data service for that. That's done. That's over. So it doesn't repeat. So there's no challenge, there's no problem with it that
Right.
people run into with it. And that's where CID remote monitoring is fundamentally different. And I think some of the
Right.
sources of the confusion over as the technologies change so much, even across the entire landscape of remote patient monitoring, so to speak, and this is
Mhm.
something that's rapidly progressed and is only going to continue to get more and more complex and faster.
Mhm.
It does become a continuous care model. So RF CIED based devices are just fundamentally different. It's not a single point in time. It's not a later interpretation of a single, diagnostic interpretive event.
Right.
It's a span of continuous care that can constantly and often does constantly send transmissions. And again, back to your point, I think of the scheduling aspect, I think has allowed us across the board to be stuck in the single point in time because unless billing departments, compliance departments, and clinical folks are getting together to actually look at what kind of service this is,
Mhm.
you will always run up against the challenge of trying to chase a time frame based off of a signature that feels in the old model like a single interpretive event. But back to your point, during a 90-day window, you may have alerts come over for new onset AF, for example. A device technician gets that, sends it to a nurse or an APP who then calls the patient and then gets in touch with the physician. Anticoagulant is started. And that could be 10 days into the cycle. And then 30 days into the cycle, they have RVR, for example. Somebody sends a secure chat to a doctor, writes a report up. They call the patient, start them on beta blockers. And many things can happen during that entire time. And then come to day 90, if, say, the patient isn't there for the transmission, or if a physician signs it later, if there's always adjustment based off of that signature, all of billing is lost for work that was actually done by teams. And to your point, the revenue part of it can be very difficult when anybody from administration is looking at the revenue and the income from the clinic and it doesn't support maybe getting another FTE. If the
Right.
if many of the things that I've had discussions with other institutions is they get frequency edits, so get to not because something
Mm.
is a little bit shorter of that 90-day window. And
Right.
we can go into that just a little bit here, but and look at them side by side, kind of the ambulatory language and then some of the other language around the CPT codes themselves for CIED monitoring, and continue to have that discussion on what is kind of the most appropriate way that's allowed for based on the language and also reflects the service. And I think there are some things that we can look at that does reflect the service, and is a great thing for all of the various different stakeholders to have a discussion around.
Yeah, and I mean I think that when I think back to so when I went from being a device nurse to going into a management role, one of the things I really struggled with was the business side of cardiac device clinic. And it's one of those things where, but what I realized was I did need to understand what was happening as far as denials, reimbursement, what our billing cycle really was. And then when we started throwing in things like remote monitoring and alerts and all this stuff, and I realized that I had to have the staff, but then I couldn't tell the story because it didn't match the number of encounters we had, the amount of revenue we were generating, even though I was telling, even though, I always told this story, hey, my staff, they're highly trained, they're experts, they are revenue generating. When they do a home transmission, there's revenue tied to that. When they are seeing patients in the office, there's revenue tied to that. But what I was struggling with was understanding that continuous care model, which is what we're talking about today, and being able to tie in the fact that lots of things could happen during that 90 days. To your point, a patient has maybe a little run of AFib and we document it. We don't necessarily do anything. We call the patient to make sure they're okay, they're still on their medicines, blah, blah, blah. So this can go on and on, but we have to be able to talk to that. I think what I'm hearing from different clinical folks is that where this push pull is exactly what you said, Ken. It's that ambulatory cardiac monitoring. Well, for Holters and MCOTs and stuff like that, makes sense, right? Because
Absolutely.
patient puts it on, they wear it for a certain amount of time, they take it off, the doctor reviews it, one and done. 98% of the way healthcare works, the way patients are provided care, and the way providers bill for it is one and done. It is date of service. It is
Yeah.
an encounter.
The fee for service. Yep.
Right. It's fee for service, right? That's the traditional model. And I think a lot of times in device clinics and stuff, and when I'm talking to other device clinic folks, like we feel like we're a really big deal, and we are, but we're really sort of a microcosm and sort of this little niche within a massive amount of healthcare that's taking place. And I think too, that's where um, we have to understand sometimes why we feel like we're having to advocate and we're having to talk about these things over and over again. And we feel like it should be intuitive to people outside of device management, but it's
Right.
not. And I think that's where if anything, you and I are hoping to get across to clinicians and compliance and the billing folks and administration is we get it. This doesn't match what's happening
Mhm.
in most areas, including ambulatory cardiac monitoring. We get where we're really close to that, but we're still implanted devices. These patients maybe, I mean, we take care of patients that are in their 50s. They've had a
Mhm.
pacemaker since they were 6,
Yeah.
right? So these patients they're ours forever. Like and it is continuous. We might bill on that 90-day and do a scheduled transmission, but we don't stop providing care until the physician signs off on it,
Yeah.
right? Like, you know what I mean?
Yeah,
Like
you
there's
could
no
have an
stop.
alert come over the next day, one following that.
Right.
That's that
Right.
continuous care model. They're constantly connected, which is fundamentally different from your point of an ambulatory Holter monitor.
Right.
Yep.
Right.
It is
But
single and it's done. Yeah.
right. And I know you've put together some information to kind of help us understand even better, I think, why that confusion exists.
Mhm.
Because I do think from the clinical side, we don't, it just makes so much sense to us what we're doing and how it's doing, how we're doing it.
Sure.
But it can be really hard to tell that story and get on the same page with the folks that are really our gatekeepers to make sure we are compliant with billing.
Absolutely. And I think to your point that sometimes and I'll put like technology back into the mix of things as technology has advanced so rapid.
Mhm.
It's even hard for clinical side to keep up with every bit of new technology that can come out. We're increasingly living in an age where the body's connected to something in some way, shape, or form and has the ability to deliver diagnostic capable things on an ongoing basis across the board to a caregiver. And so it has drastically moved past that point of, a single point of service that is all encompassing for that time, for that given point in time. And I did what I'll pull up here in a second is because I do think this is important because of many of the conversations I've had with different institutions at different places, where there is some friction or trying to figure out how to approach this and understanding really what kind of service CIED monitoring is, it does tend to get lumped back into the ambulatory monitoring, which is completely understandable. But I think the whole point of this conversation is what we want to show is how it is fundamentally different. A lot of what we just described is giving those scenarios. And I would even encourage anybody on the call that if you were working with your compliance and billing department and you're a clinical person and vice versa, get together and go down and look at the workflow, look and see what happens. And coming together, I think will help us keep up with the technology because it's probably going to continue to change. I would say it's certainly going to continue to change. So I think sometimes misunderstandings or confusions around different things are the fact that the technology has grossly advanced rapidly, turning
Right.
what was a simple thing in time to an ongoing, continuous point of work that has to take place across the board. Let me share my screen here real quick, if you can all.
Yeah, and Kent, while you're pulling it up, I do want to say that being able, again, to tell your story, having administrators or even your compliance and billing folks just like, hey, come here, let me show you what one of my home monitoring nurses does. I'm sure they would have no problems pulling up a patient who's had frequent alerts. They've sent multiple messages to the physician. They've changed medications. They've called the patients. They've done all this work. You know, before remote monitoring, what would we have done? Patients would have called us. They would have said they had palpitations. We would bring them into the office. We would check their device. We would bill them for that service. The doctor changes the medicines. They want to know, did it get rid of their AFib? Is their heart rates more controlled? What do we do? We had them come back into the office, maybe a week later, maybe 2 weeks later. We checked their device. We wrote up a report. We billed them for that. So if you think about it, really, we're delivering more care with less opportunity for billing for the care that we're expected to provide, that we have to maintain the staff, we have to maintain the expertise, we have to maintain all the things that are involved in doing that. And this is where I think it's so critical for everybody to get on the same page about what home monitoring and continuous care really is for patients with implanted cardiac devices.
No, you're absolutely right. And it is fundamentally different from any other remote monitoring type of service with its RF capability around the clock. And with the recommendations of it now being the standard of care,
Right.
there's, in 2023, HRS released their new guidelines and that became the standard of care. And within that was a lot of recommendations that are centered around the changing nature of how remote monitoring and CIEDs is done because it is continuous. So in the past, before that, you could have a single person do a fair amount of devices, maybe get the remote one that's inductive that was sent in, come over, read it, see people in the clinic. With RF, now everything comes in constantly over time. It could come in day after day after day. So it doesn't really stop. It has the potential to not stop. And I think that's the important thing. And so what I've pulled up here, can you see this, Beth?
Yes.
Okay. So what I've pulled up here is a common, matters document that a lot of times people will discuss when it comes to compliance or billing around how they should bill or code the 93295, 296 codes when it comes to CIED remote monitoring. And what is interesting about this that I think is important is it acknowledges right off the bat that there are many procedure codes that represent cardiovascular monitoring services. And this was revised in 2019. There's many, 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 probably more now. But
Yeah.
yeah, so, and then it talks about identified by professional component, technical component, combination of the two. So I think what's important here is the examples that this gives in this document is that here it says the monitoring can take place in one single point in time. Others may take place over 24 hours, 48, or 30-day period. Those are all ambulatory type devices because they're done at the end. What is interesting is it says the determination of the data service is based on the description of the procedure code itself, which that right there should move us directly to the CPT codes for remote monitoring.
Exactly. Yeah.
And we'll go, that is below, but what I will say here is that it gives an example. So like when the physician includes a physician review or interpretation or report, singular. That's very important because ambulatory monitoring is at the end of that 24-hour, at the end of that 48-hour period or that 30-day MCOT period. It's closed after that. So
Right.
if the physician signs it, physicians are going to sign at various times. They're busy. They're going to have various times. But when it's attached to that in a single interpretive event, you don't run into any billing problems usually because that's it. Nothing picks up after that date, which is
Right.
another fundamental difference in the CPT codes for ICDs and pacemakers. So again, so I point out that the guidance even tells us, go from here and look at the CPT codes. The example that this is saying on the professional component being the date the physician signs, it is referring to an example for ambulatory monitoring, not referring.
Right.
But even if we do go to the CPT code, as it says, this is where we get into what I've been talking about, Beth, that the code itself, the CPT code itself, is describing that continuous care model because it's talking about span of time for 90 days with interim. And I think interim is an important word. It's Latin for the in-between. So everything in between that time, from an analysis to reviews, plural, reports, plural, by a physician or other qualified individuals. So you're going to have physicians sign off on things. You're going to have APPs look at things that don't get routed as billable per se, but all of these different scenarios are taking place during this 90-day stretch of window. And in the interim, that's where reports, reviews, analysis is done. So it's very difficult to not read that or read that and then try to transpose a physician's signature date for the professional component because there is no one single point. It's just at the end of the 90 days. And people can give countless examples like we did with the AFib, all the various things that are done, the triaging of the transmissions, the optimizing of the alerts. So they're not coming over so constantly in certain areas that you need them, always having to have somebody available to field those things, whether, from the administrative side to keep people connected when they become disconnected, all along those lines. So this is where I think what's very important conversation to look at closely. And it's, again, I will be honest, there's not a single document from, on CMS side, you can see that nails all of this down that says, it just doesn't because it's just rapidly evolved. But looking at the CPT code itself, it does give you that language. This is a period of time. And it's going to have multiple interpretations, multiple reviews, reports. It's not a single, interpretive event. And that is basically said right in all the CPT codes. So, let me
Yeah,
go.
the code, the CPT code does know what kind of service it is, right? The
Yes,
CPT code the CPT code really does give you that language. So we just don't have the guidance. What I hear you saying is we don't really have the guidance documents and things like that to really clarify the way that it would make it simpler when we're trying to have these conversations, right?
Yeah, it would make it simpler.
Right. But the good news is Don't lose hope, people that are out there advocating for this is what we actually need to be billing for, and how we don't want to be stuck on that physician signature date because it's going to throw everything off. And I think people think that the reason they're getting denials and things like that or frequency edits is because of the physician signature. It is if you're hanging your hat on it. But again, if you look at this CPT code, that's not what it's saying. And interim, to your point, is really important. And I wonder how many times people glance at interim and think interval, and then we get stuck back again in that on 90
Yeah.
days, I'm going to do a scheduled transmission. It's a date of service. And again, I think this is just, we grew up this way. This is how we've grown up. This is how, again, most of healthcare is delivered. And
Mhm.
you really do, it's a paradigm shift. It's a culture shift. And in healthcare, nothing shifts quickly. Now, the technology for us has changed rapidly.
Yes.
But that's not how healthcare as an institution and you know what I mean? God, that's not how the institution of healthcare, it does not change rapidly.
No,
Um,
no. And you have to have conversations like this, and especially as rapidly as the technology is changing. I mean,
right.
completely as rapidly as the technology is changing. And to your point, talking about earlier, like people, billing compliance, clinical administration, getting together and looking at these things, I know has been very helpful with some of the institutions that I've worked with because you can see in the period we're all in a habit of doing things that we've done always before, and it takes a bit of time for those things to kind of creep up on you. But in several instances, some compliance billing departments and clinical and administrative got together, looked at this and said, okay, well, let's go to our local MAC, talk to the local MAC. And, I know Palmetto has, Novitas has with other institutions said, oh, yeah, that makes sense. Do it 90 days. So again, that just kind of goes to show that it would be nice to have CMS come out with a very clear statement because
Yeah.
this is what happens. And I think one of the things that we see a lot when CIED remote monitoring is treated like ambulatory, and based on this statement of, the DOS for the professional component is when the physician signs, you I mean, from an ambulatory stance, there's no argument there. That's being read completely perfect. The hanging part is CIED remote monitoring is not ambulatory monitoring, and that's the CPT code description tells you that, this is 90 days with interim reviews, not a single interpretive report, and so you can
Mhm.
have multiple times where physicians review several reports during that time. That all meet and show that clinical care that's taken place. So, what this really comes down to, I think anybody maybe on a compliance or billing side, they have an extremely important job. Their job is to make sure that the institution exists.
Right.
Otherwise not. So,
Right.
it is something that I think every side needs to come together and appreciate each other's function that they do, and then also realize that these technologies have changed, and get input from your compliance and billing folks, have folks come down if they never have, to look at what your clinic is, talk about
Mhm.
this. How could you even go to your local MAC if anybody was having issues on how to approach this? It's certainly worth a conversation. But one thing we have seen that does happen, it goes back to the revenue. When you do bill on the data service under this ambulatory modeling, because the CPT code says 90 days, no more. And I'll actually go over to the next slide, which is one of the local determination readings on it. It's to be billed as a single service. And this speaks to ICDs and the technical component, and then the other one down on the bottom brings in pacemakers, ICDs, all of it. So we're seeing that CIED remote monitoring is billed as a single service, and every 90 days, and it's regardless of the number of interrogations performed. Back to what we were talking about, we have tons of them, often, all the time. And one thing I think that's worth clarifying is, I think sometimes when people read this, regardless of the number of interrogations performed, That does not mean that the clinic is reaching out saying, send me an interrogation. These are automatic. They are triggered in the device based on clinical events that can be life-threatening, and they can come over in masses for any given patient. There are also alert events that they may not even need to be reviewed because they're repeat,
Hmm.
but they still have to have somebody qualified who can make those decisions that they're seeing them. That's kind of the hidden part of the work that I think it would be very helpful with clinical and compliance and billing getting together to see that work and then have a discussion on how your institution wants to make sure that that's accounted for, that fits,
Hmm.
what your institution is comfortable with. So
Yeah, and I have seen that firsthand. I have been that clinical leader that brought in an administrator or a compliance expert or billing expert and said and asked them just to sit with, like, one of the lead home monitoring nurses and have them under, especially when they pull up four different home monitoring websites and they talk about red alerts or yellow alerts, and then the button, you know what I mean? And then they
yeah,
start talking about, like, maybe just drill down on a particular patient who's had certain things happen. And maybe this nurse has even had to call the patient and say, are you okay? Do I need to call 911? Like, there's so many different clinical scenarios, but getting that point across that this is really important care. We know that home monitoring helps to keep patients out of the hospital, and it actually keeps them alive. And so this is where, but again, think about it. If you're a billing person and you don't know anything about device management, and you have this ambulatory, remote monitoring service thing that of course, how could you understand it? This is such an odd little, it's such an odd niche, and it's
yes.
not the way it works in anything else. But I think that's where we as clinicians have to be willing to say, we have to be able to tell our story. They'll meet us halfway. They can help us with this, but we can't just sit back and act like we don't want to be bothered with it because we don't like to talk about billing, right?
Yeah,
Yeah.
no,
Yeah.
it's very, very true. And and I think one of the things with the billing as it sits right now, where if it's practiced on the ambulatory model in the CIED environment, um, many institutions get lots of frequency edits. They get just an automatic kickback
Hmm.
because it's being based off of the physician's signature, and is going to inevitably be less than 90 days, from one cycle to the other, because this is a 90-day period that begins, as this says up here, with the initiation of the remote monitoring or the 91st day from the prior. So instead of this being one and done at a signature date, it's done at a interval cycle on a time
Hmm.
frame of that continuous model. And again, because you can go back to the CPT code description and it does seem to recognize that this is continuous because it's inclusive of all of these in the interim, in between that time, all the reviews, all the analyses by physician,
Hmm.
by other qualified healthcare professionals that have to reach and manage these patients. So it really, CIED monitoring has to be sat down and looked at closely if anyone's billing it within an ambulatory type model. And then, I'm sure people can make various different cases on why this is how fit, but in many times, often people will get things kicked back because even though that same 90 days happened and you could have an entire period of a lot of work being done that the clinic should be getting reimbursed for, doesn't
Right.
get reimbursed because it's denied. Um,
Right, right. And I think, I know that when I would get patients that would call me and they would be upset about their bill and they would say, what am I getting billed for? I didn't even come into the office, or nobody called me. Nobody told me there was something going on. And I would explain to them that, that transmitter that sits next to your bed can send us information 24/7. And that's great because we know, and the reason your doctor wants you to have that monitor is because we know that things can happen. You could have an abnormal heart rhythm in the middle of the night that could be harmful. You could get shocks that you didn't know about, or your battery could be depleted, or you're affected by an advisory. And we're expected by the FDA that is an expectation that we help manage and keep you safe because there are things that we need to watch and monitor. But I would say it's like having a home security system. So, in other words, it was an analogy, it was the only analogy I could think of that would really help understand, no, we're not in your house. Nobody, or your security system isn't standing there in your house. But what they're doing is monitoring because if somebody else comes in your house unexpected, right? They're ready to call the police, alarm you, like all that kind of stuff. So, home monitoring, as far as explaining it to patients and helping them understand is that this is because we need to be ready to help you if there is a red alert or a yellow alert or there's something unusual that happens so that we can help keep you safe. And then when you add in that extra level of things like all the heart failure monitoring technology and things like that, like again, this is what we're trying to do is say, hey, we need this foundation of continuous care model because it's only going to expand. We're not going back, right? Like it's not like the way the
It's already
technology
here.
is going to your point. Like years ago, we would never have considered only bringing patients in once every 2 years,
Right.
even with home monitoring. But now we realize that with home monitoring, as long as we're making sure patients are connected, that is safe to do in many instances. Maybe not for every single patient, but again, years ago we would never have considered that. And it has just moved so fast.
Yeah.
So, I'm glad we're talking about this because again, I think we have to think about the language. The word interim isn't a billing technicality to us. It's an actual description of what we're actually doing for our patients. So, again, I think that continuous service and model is what maybe will help tell that
Yeah.
story.
I think so too. And people coming together, having discussions around it. Again, because I do think that just as much as the technology has changed and everybody has to rapidly adapt to it and adjust, whether it's from an operational standpoint to provide the best patient care that we can, given this flood of information that these devices now allow us to have. The language around reimbursement for those real clinical things that are taken care of, for the real care that needs to be
Right.
taken care of, needs to be understood so that clinics are billing for what they should rightly be billing for the work that's actually done. Otherwise, they won't be
Mhm.
able to support the clinic with the staff and the experienced staff that they need to address this flood of information that's already coming in and will continue to come in. So I
Mhm.
guess with that being kind of said, I know we're coming up here with about 10 minutes left. I wanted to stop, maybe just open it up for
Yeah.
questions and see if anybody has any thoughts. I don't know if I can see questions. Can
And it looks like we do have a couple questions.
I? Okay, I can't see any here, but if you want to
Yeah,
read.
I would take some few. So the first question is, do you think device clinics need to be monitoring remote websites 24/7?
Um, I'm happy to take that one. Uh,
Okay.
I can share an experience with that. And here's a reason why. I would say no. I would say, and the reason why is so when we say 24/7, the device does have the ability to send something over, at any given time. But I think you have to be very careful about that, especially around when it comes to patient understanding and patient education.
Mhm.
Um, because this has happened before in the past. The patients have thought, oh, they've been told it's being monitored 24/7. Somebody's monitoring it, and they were like, great. They had chest pain. Of course,
Mm.
your device isn't going to say anything about that. And didn't go to the emergency room because they thought somebody would call them if there was an issue. So I do think that it's important to say that, this is a continuous ongoing service. When we see something, we'll be able to get it to you. You don't have to always come into the office right away. We're doing this continuous monitoring. However, it's not a replacement for 911. If you're experiencing chest pain, any kind of problem that's really concerning you, you need to go to the emergency room.
Mhm.
So yeah, it's just it's a matter of perception to the patient. And when we did a lot of patient education on that side of it, people didn't have a problem, they understood. It's when that's the perception to them is, oh, this is 24/7. They're monitoring it 24/7. And in the patient's mind, they think of that as like, oh, this is like my life alert, help, I've
Right.
fallen and I can't get up, type thing that somebody's going to come get them. But that's just not the case because there's many
Mhm.
things that could be an emergency with the patient that doesn't have anything to do with the device that they can mistake it for.
Yeah, and I mean that's a great point. You have to do the patient education and we have to be careful about our words, right? So maybe a better way to say it is we get data from your device
Mhm.
24/7, but we're here, in the office or we have people assigned on, Monday through Friday. If you feel bad, if there's if you have any questions, that's when we used to tell them to call into the clinic and they would get the physician on call or somebody who could say, yes, I need to look at this or I need to, that kind of thing. But to your point, Kent, we have to make sure it really is about patient education so that
Yeah.
they understand what's really happening because it's not, is it feasible to have device clinic staff on 24/7, 7 days
Yeah,
a week? No.
that's the other thing.
I mean, I guess it could be, but
Well,
not
I
for
would
most
even
clinics.
I
And
would
I don't think
even
it's necessary.
no, because I would even throw this out there. If you had people monitoring the websites or whatever 24/7, um, you know, uh, even if you did get something that's extremely emergent, what are you going to do? You're going to call the patient, tell them to go to the ER. Most of the time, there's
Right.
going to be some kind of something associated with that.
Mhm.
I can't think of an example per se. There may be one, but where if I'm monitoring a website at 3 a.m., I get a transmission that comes over that could be deadly to the patient, but they don't know. Maybe if it's it could be maybe a recall along those lines or
Mhm.
something like that. But those usually come in protocols where, you establish something with the patient. I think it's generally better for patient safety, for them not to look at this as 911 24/7 around the clock.
Absolutely.
Yeah.
Absolutely.
Our next question, for remote monitoring, do you require a consent form from the patient saying when can use the home monitor? Our compliance insists that it is required to be renewed yearly.
Yeah, so I mean that's a great question. It is yearly, in many regards. That's kind of the prescription. They need that on it. The patient consent form or patient agreement. Many places will call it different things depending on how your legal department looks at it. Because a consent versus agreement might be able to not have to go through so many different avenues. But the point of it is that it is now standard of care. The physician is prescribing this to you. You yearly prescription of it. It's going to give, it's still right back to the codes. It's continuous service. You can get things all along. You can only bill every 90 days. The major part about the agreement and the consent form is part of the education to the patient so they know what it is. One of the biggest challenges I think that a lot of institutions have had in the device clinic, and then again, this goes back to how rapidly this technology advanced, is, patient goes home with a monitor, they don't even know what it is really.
Mhm.
It gets sit down by their side. Maybe they don't come back for a little bit, especially if it's an ILR. There's not an education component to it. Because clinics everybody's very busy. And then inevitably that patient gets a bill at one point and they don't even know what it's for. And next thing they know, they're disconnecting their monitor. They don't want to have anything to do with it. It also leads to other, you know, excessive billing questions from patients coming into the clinics. And it's all centered around that nobody has just had sat down with them and explained to them what this is. And part of
Mhm.
that consent form or agreement is to establish whatever your clinic wants to have as their protocols. Some common ones are, we will be monitoring your device daily. It sends over automatically, for our office hours from 8 to 5. Also, many of them in there will have, this is not 911 to clarify
Exactly.
that. If you're
Mhm.
feeling symptoms or call the clinic. So there's all different ways that clinics can do it to meet their own goals and procedures. But I think the key points is what it does is it explains to the patient, you're going to be monitored kind of continuously. And then a very
Right.
important part of it is the billing component. Um,
Hmm.
and making a statement in there that you may receive copays for this. You will be billed every 90 days. This is an ongoing service and independently of your in-clinic visits. But it's something you want to sit down and have a conversation with a patient, say at their first visit, when you're telling them about the remote. When I have done that in the past, we went from, and this was kind of in the earlier days, we went from where people were calling in, why am I getting billed, disconnecting their monitors, these kinds of
Hmm.
things. And when we decided to come up and even formed a committee on what we wanted to put in there and then spent that extra, it really takes 10 minutes. It doesn't take that long to explain to a patient when they first come into the office is usually the best. Um, you know, um, they had no problem with it. Billing calls just went right away. Maybe, I don't know, a fraction of a percent of people would just be, no, I don't even want to do that. Okay, fine. You don't, you're at least
Right.
you have informed consent. Yeah.
Right. They're within their rights to refuse it. It's all about being informed. And,
Yeah.
you know, we tried to start even before the patient got a device. So even when the physician is talking to them about you need a pacemaker, or we think you need an ICD or a loop recorder, and by the way, there's going to be home monitoring involved, and this is how it works. And this is, I think the earlier you start those conversations, the remote monitoring agreement, I think, is a great way to just it makes sure that you're teaching the patient all these things. You give them something they can take home. But you have to keep reiterating it too, because a lot of times, especially when patients first get an ICD or something, nothing really happens. They're routine every 3 months. Then things start happening and they get sicker. And then there's more, again, back in the old days, we kept bringing them into the office. That made sense to them. They were in the office, they were getting care. Now, what's harder for them is we're seeing things, we're calling the doctor, we're changing a med, we're whatever, you know what I mean? We're taking clinical action, but we can't bill for it except once every 90 days.
Yeah. So, I mean, yeah, exactly. And so, Kate, to answer that question, I would say absolutely. You should have a patient consent, patient agreement.
Mhm.
That's just what spells out what the service is, and that it is the standard of care now. And it also what it does, it adds a little bit of quality to their life too, because anything that you didn't know in the past, if there was somebody didn't feel well or had a symptom and they called up the office, they had to come in. They had to come into the office and they would get an interrogation, they would get a bill for it. Now there's many things that during that time, if a patient has a problem, they send a transmission over. The clinic can review it remotely, call them on the phone and say, no, everything looks good. We'll continue to monitor you. So, and they don't get a bill for that. That's in that 90-day window. So I think that's an important
Mhm.
thing to realize. That goes back to this being an interim service over a 90-day period, because so many examples like that happen all the time. That in the past, the patient would get a bill because they came into the office. So now this covers like all transmissions, interrogations that come over, alerts, patient initiated transmissions, that otherwise you wouldn't know. The patient would have to come in, they would get a bill for. So
Mhm.
with the way that the CPT code description is for CIEDs, saying all of that stuff, and you can only bill it 90 days. So it does save the patients. I think where the challenge comes in, if you're in a billing department or even a clinical department and patients aren't aware of what it is,
Right.
that's what creates all of this. Lots of calls, feeling like they're being billed for something that they're not utilizing. That can be stopped pretty much right in its tracks with patient consent agreement that you sit down with folks in your clinic, administration, billing, and talk to each other about, and include a billing part in there. And once they know what the service is, again, I'd say 99% of the people that I've ever talked to over the years
Mhm.
in a clinical setting that were patients had no problem with it whatsoever.
I'm going to ask this question next because I think it's applicable to everything you both just mentioned. So it says, I understand the interval is 90 days, but if we are pulling a transmission in the beginning, middle of the monitoring period and using that as the report, can we really be billing it at the end of the interval if we don't have the data from the end of the 90-day period on the report?
So I think that's a great question. And this goes back to, so one of the guidelines talks about, into the interval, 90 days. Again, you can have with you cannot submit a bill if you have less than 30 days
Right.
of monitoring. So that goes back to thinking, I think that's part where you're talking about pulling a report for a transmission, a single one in time. Even if you pulled a transmission at any point in that time, and the moment when you start looking at that as like it's ambulatory, that's your single interpretive event, that's where I think the language is not caught up with the actual way that it functions as continuous care. Because you
Mhm.
could pull that and then still have alerts come over and transmissions come over, but you can't bill any more than 90 days. It has to be 90 days apart. So, like in the article that was pulled up just a minute ago, if you can't bill these codes any more than 90 days, and you have to have at least 30 days of data. What that tells you kind of right there, you could have a transmission come over that you pulled or scheduled at 60 days, right? You could write that report up, send it to your physician, have him sign it at day 65. You can't bill that until the end of the 90-day period. That's
Mhm.
the rule. If you tried to bill it at that 65 day, and you had another one that was on the 90-day cycle, that's where these frequency edits come back. They're not even seen, they're just kicked back because whenever you're trying to rotate that date around the end of the interval of 90 days, and it doesn't match up with the last one that was submitted, it gets kicked back. So
Another question tying to this, can billing be automated every 91st day for devices that have confirmed ongoing connectivity? If so, what platform allows for this?
That's
Mm.
yeah. I mean, anyone can, and most platforms we do. Care Cycles is set up that way. That's actually kind of the point of it. The way that is, it tracks that 90-day window, and you can see in Care Cycles the whole how many transmissions may have come in when that 90th day ends, and more importantly, back to the point where I said you could have several transmissions come in, some of them reviewed, signed off on by the physician, some of them double checked with the nurse and they sent a message to administration to bring the patient in, talk to the doctor in the hallway, discuss what was going on, because this is a continuous service that's happening. And then you can and then it tracks that. So then you can have a transmission date that comes over back to the point of no less than 30 days. So you could be 60 days in the cycle, have a transmission that's at that 60th day with the transmission date, have a physician signature that's on the 65th day. And then within the tracking like Care Cycles that we have, the date of service is based off of the 90-day language in the CPT code, because it does match that. You can't use that 60th day transmission date or
Right.
that 65th day physician date. You would be violating the 90-day service.
But I mean, I think that's a great argument for having a platform, a CRM platform,
Yeah.
because it's so, especially when you have thousands of patients, or even if you just have 8,000 patients and you're doing home monitoring, you want to be able to bill for that service you're providing, right? But the way that you kind of have to do it is that every 90-day scheduled transmission, which I feel like we need another word for it, because really what we want to do is say, during this past 90 days, you know what I mean? This is the overall view. The physician gets a report, we sign it. That sort of helps us fit in to the compliance needs and the billing structure that is set up. Really, what we're so anyway, this is where I'm saying is that having some place that helps you keep up with that 90 days, because asking clinicians to understand the last time a bill actually was dropped or reimbursed or went through or and doing it, because that's not about care at that point, right? We want your clinicians to be involved in providing the care, um, this continuous care that they are being asked to provide through a patient's home transmitter, and not which is why, again, please don't get hung up on that physician signature and even
Wonderful.
the data service, right? But that physician signature is probably kicking a lot of people in the butt as far as trying to get their billing
Yeah.
frequencies correct.
I know we're at time, so I'm just going to answer we're going to answer a couple more questions.
Okay.
If reimbursement were to change and all alerts were reimbursed, would you advocate for alert-based monitoring? Would it relieve the no action data burden off clinics, but allow for fair reimbursement?
So if I understand that question correctly, you're talking about being able to get reimbursed for all alerts.
Mm.
Is that correct, Kate?
Yeah, I think it's a hypothetical if reimbursement were to change and if
Change
and
to
all alerts were reimbursed, would you
okay.
advocate for alert-based monitoring?
I think that it's an interesting question. I think it's a good question. The first thing that comes to mind is that you would be kind of going right back to if you were billing for every alert that came in. I don't know what that would be. The charge for that, it could be pretty expensive, probably. It would be just the same as before we did RF monitoring. You would essentially be saying if you had an issue that was probably we bring you into the clinic, bill you for that for the clinic every single time.
Hmm.
So yeah, the alert based only has been something that's been talked about, and I think one of the difficult things kind of around it is, you know, and is that how do you get reimbursed for it, whether it's per the alert or whether it's the end of the period. I think one point of discussion on that, which Beth and I had a little bit of a talk about this earlier, is the fact that that discussion even comes up does show very clearly that the way the CPT codes are written, that you shouldn't be billing the date of service to your MAC based off of when the physician signs. Because the fact that you could even do alert-based monitoring as long as had somebody continuously connected, um, you technically could, as long as you could show that they were connected for at least 30 days
Right.
constantly. And then you would have to have, in order to get billed for it, or in order to bill for it, you would have to have a system that is not tied to a single transmission, which is what kind of the confusion is right now. The billing date would be the close of the interval every 90 days, but you would have to make
Mhm.
sure that that patient was connected. So it's a great question. I don't have an answer. I think that, again, there's a lot of these things that are worth discussing, and all of them kind of point to what I think is very important today about what we've been talking about is how different this is from ambulatory monitoring and what has been tied to the billing view in kind of an older era, which makes complete sense. It's nobody's fault. It's the technology has changed, is that this points to how different this is. You can't it,
Mhm.
we need to have conversations on how this is completely different than ambulatory monitoring. It's not one and done. It could be continuous, but it's got to
Mhm.
be a 90-day window. So it's a great question, and I know there's been some discussions and actually a little bit of lobbying to increase the technical component side of the reimbursement because of the nature of a lot of the alerts that come over, the noise that still has to be filtered through. You can
Yeah.
reduce noise for sure. It'll never go away, but you can definitely reduce.
Well, yeah. And I do want to say one thing about the alert monitoring. I mean, do I think alert monitoring, being able to go to that sounds great? I do. Do I think we're there now? No. And the reason I say that, there's too many different types of advisories. There's too many things that can happen in a device that may not trigger an alert,
Great
but
point.
could be very significant to the patient and cause harm. And so I think until we've actually have devices and we have that kind of technology, I just don't think we're there yet to do it safely either.
Yeah.
So, for me, that's just my opinion, but I don't think we're there yet. And that's why I think it's, again, so critical that we get this right and that we come together on what continuous monitoring and care is of patients with implanted devices, because it is not the same as a Holter monitor. It is not the same as most of the things that are being billed in healthcare, but it is very significant, and we've got to find a way to make that framework work for all these hundreds of thousands of patients that are receiving home monitoring and get it right, because most people need more staff. They need a platform, and they're going to have the revenue integrity to support that. So hopefully we're giving them those tools, Kent. That's the hope.
Thank you. So last question is actually two questions, but from the same individual. So I'll tie it into one question. So for remote monitoring of pacemakers, is it best to use for tech and profesh codes 93296 and 93294, or do you suggest 93293? What about loop recorders implanted in billing every 31 days? What is best profesh and tech codes to use for that?
Yeah, so most places we've was 93294, 93296 for pacemakers, and 93295 and 93296 for ICDs. And when they got rid of the G code, the loop recorders are now, it's just one, it's global, 93298, I believe. So yeah, and with the loop recorders, it's still the same principle. You're still, if anything, gosh, the loop recorders generate way more data that comes over off of everything. So we're still talking about RF continuous monitoring. And I think that's really kind of these are all great questions. And they're ones to have with your institution and showing people how it works, how you are working, how this is continuous care. It's not a single interpretive event. So the points of like the 90-day and why we do a schedule of a 90-day, back to Beth's point on versus continuous alert monitoring, and not doing the schedules. That is very important. The reason it's still 90 days is because you still need a transmission to come over, because there's many times you might not get an alert. I'm sure plenty of people on this call have seen, scheduled report come over or a patient initiated report that didn't have an alert attached to it, and they were periodically losing capture.
Right.
And so that's the kind of thing. So I think it's important to realize that the 90-day scheduled transmission that we have doesn't mean that this is not still continuous care, that it's now a point in time at that 90-day. That's just that verification that there's not anything else going on that didn't get alert during that continuous care thing. So that's why the 90-day is not the 90-day transmission itself is not that one report in time. That's where I think people keep going back to ambulatory devising or ambulatory billing, as if it were a single interpretive event. And that's where I think the conversations will really have, because what you're talking about is billing for the things that are appropriately and allowable for what you do, for the work that's done. It's not talking about billing any more frequently than you need to or anything like that. What's actually happening in a lot of the places we've talked to, it's just the opposite, because the billing is not being adapted to the rapid advancement of the technology. There's a lot of clinical work that goes in that never gets reimbursed.
Well, thank you, Beth and Kent, for sharing your expertise, and thank you for everyone who joined us today. At PrepMD, our goal has always been to support you and the device clinic community with more than just a single solution. Whether it's CIED software, education, remote monitoring support, staffing solutions, or ongoing professional development, we're committed to providing you the tools, the resources, and expertise that you need to remain successful, independent, and resilient through your turnover or change. We hope today's session offered a new perspective on billing and compliance, one that moved beyond simply submitting claims and instead viewed reimbursement as a strategic component of a high-performing device clinic. Thank you for being part of our community, and we look forward to continuing the conversation. If you have any questions or want to continue this conversation, you can email us at hello@prepmd.com. I also saw some questions just came through the chat, and I'm sorry we can't answer those, but we'd be happy to continue this conversation. Kent is always willing to speak to anyone who reaches out at hello@prepmd.com, and we want to especially thank Beth Davenport today as well. Take care, everyone.
Thanks, everybody.
Bye. Thank you.